Well, it's good to be here. I haven't been actually here, I think, in a couple of years. You know me, I'm Olga Klinkova from Moffitt. And Dr. Katzman asked me to talk to you guys about CMV and transplantation. And I agree it's hard. And some of the things you would just have to memorize. And that the things I will try to explain so you kind of have better understanding to remember better. But it's a hard one, that's for sure. All right. So first of all, just a very quick review of host immune response after CMV infection. So as we all know, once the primary infection occurs, the virus will enter into the latent phase. And during that phase, there is a very strong T cell response ongoing. And that is why, essentially, if you have a normal immune system, you're not a transplant, clinically significant reactivation does not occur because our immune system dedicates a portion of work just to keep that CMV virus under control. However, in certain cases, such as if you have a patient with transplant, post-chemotherapy, and very occasionally in settings of severe critical illness, you can have CMV viral reactivation, which would be clinically significant. Move to the next slide. So I have a few questions, not as many as Dr. Brook had, but we will talk them through and go through all of the choices. This is a very testable question. And again, sometimes it's difficult to understand, but you have to know this. So question number one, in patient population undergoing allogeneic hematopoietic stem cell transplant, which patients would be considered at highest risk for CMV infection based on pre-transplant donor recipient CMV serology status?
D.
Sorry.
Perfect. D. So they will give you these four choices, and what you have to remember, who is the highest risk? That you have to remember for solid organ transplants versus hematopoietic stem cell transplants. So you're absolutely correct. It's D. So remember that if you look at age-adjusted status of CMV in like entire population, by age 40, about 50% of adults were CMV positive, right? In some of the countries, and as we age, that number goes up, and in some of the countries, up to 90% of population is CMV positive. So it's one of the most common latent infections that the majority of us will acquire with age. So specifically, if you look at the transplant population, and in terms of who is it at your highest risk, if you look at the organ transplant, it is donor positive, recipient negative. And remember, in stem cell transplant, it's the opposite. It's donor negative, recipient positive. And the explanation behind it, specifically for organ transplants, remember that if you are recipient positive, there's a presence of CMV specific cell mediated immunity, and that's why you have some forces in your body to at least keep that infection under control. So those patients are considered to be at intermediate risk, the highest risks comparing to donor positive, recipient negative. And specifically for the stem cell transplant, multiple studies showed that recipient positive patients are at highest risk for having CMV infection or disease post hematopoietic stem cell transplant. If you look at other mismatches, of course, donor positive, recipient negative, they are at risk. Specifically, they're at risk for primary CMV transmission, but their risk is not as high. And again, the explanation behind that is, remember, before stem cell transplant, our patients receive very aggressive conditioning, right? That completely eliminates your immunity, and immune reconstitution occurs very slowly. All right, so we will move to study question number 2. So you have a 36-year-old female with a diagnosis of AML, admitted to undergo allogenic matched and related stem cell transplant for the treatment of AML. She's receiving your standard conditioning, fludarabine, busulfan for GVHD prophylaxis, as you can see, also standard with post-transplant cyclophosphamide, mycophenolate mofetil, tacrolimus. This is her CMV serology status. So she's donor positive, recipient negative. So based on what we just discussed, is she highest risk, high to intermediate risk, or low risk? What would you say?
Intermediate.
Yeah, so not your highest risk, right? So because of that, I'm going to tell you kind of preemptively that for those patients, we use weekly CMV monitoring. That's what started after the transplant. And you learn that at day 14, CMV PCR in the blood is 1,500 international units. The BMT team is also telling you that she just started to recover counts, and her ANC is 50, so she's still profoundly neutropenic. However, she's clinically doing really well. She's a febrile. So the question for us, what would be the most appropriate next action? You continue weekly monitoring. B, start preemptive therapy with valganciclovir. C, start letermovir. And D, start foscarnet. These options. And
Go nuclear.
we done?
Don't go nuclear.
Do we know how long out she is?
She is day 14.
Just continue
You're
weekly
gonna be
monitoring.
worried about the
Huh?
they might be worried
About
about the
the Valgan.
Valgan counts.
Yeah.
Letermovir is typically if they're already,
That's prophylaxis.
they're
Yeah.
already suppressed.
Good.
And then
So
Foscarnet.
it's the nuke.
too crazy.
Too crazy. Yeah. Yeah.
Crazy. Okay.
But you want to see CMV levels lower than like 300.
So let me give you a little bit more. So the cutoffs for CMV detection, they're slightly different at each institution. I can tell you at Moffitt, we use a cutoff of 650. Some institutions use a cutoff of 1,000. Some use 500. So with that information, I'm just telling you that she is above level of detection, right? So that's the first one. What is the issue with ganciclovir?
Further myelosuppression.
Exactly, myelosuppression. Yes. So again, this is one correlation you have to remember, that valganciclovir and ganciclovir cause bone marrow suppression. What is the issue with letermovir? It's prophylaxis, right? It's actually not approved for treatment. It has been studied, but low barrier to resistance, therefore approved only for prophylaxis. And what is the issue with foscarnet?
By kidneys.
Kidneys, exactly. So the correlation that you will remember for foscarnet is that nephrotoxicity, essentially 30% of the patients will develop nephrotoxicity. However, taken into account that the patient is early post-transplant, has CMV reactivation, and has not engrafted, the right choice here would be to start foscarnet.
So let's go nuclear.
Does CMV cause like in solid organ, a higher rate of rejection of the organ? Would that be an issue with high rate of GVHD with CMV?
So there is such a correlation, yes, but likely not as strong as comparing
Solid
to
organ.
solid organ. Yes, but a lot of other issues for sure. So based on the exam question, the STEM, this patient has CMV infection with CMV DNA emia, which is asymptomatic, right? The patient is doing well. And because she is still pre-engraftment, has ongoing neutropenia, foscarnet would be drug of choice in this particular case.
Once she engrafts, we could just switch though to Valgan.
Yes, absolutely. Absolutely, yes. So when they tell you the information about your CMV is positive, you first have to ask yourself, what am I dealing with, right? Am I dealing with CMV infection versus I'm dealing with CMV disease? And, thankfully for CMV infection, there are very defined consensus definitions. But, for your purpose, even if you're not going to be a transplant or oncology ID, this is the distinction that you need to make. So infection versus disease, they are not synonymous. So the CMV infection is defined as an isolation of CMV by culture, or you have a presence of CMV in the blood by PCR or antigenemia, or there is a presence of CMV on the tissue specimen. So, and most of what they will tell you, or what we see in terms of CMV infection, is asymptomatic CMV viremia. And this is generally discovered as a part of post-transplant monitoring, generally. So when you talk about CMV disease, you have an evidence of CMV infection as outlined above, but you have also an evidence of symptoms or signs, either such as CMV syndrome, or you actually have CMV tissue invasive disease, which is proven by histopathology. So remember, CMV disease, you have CMV syndrome and CMV tissue invasive disease. And if you're a table person like me, I put all of these definitions here. They're from one of the main papers on CMV definitions. And first, about the CMV syndrome. So here is a table that gives you in detail what goes into CMV syndrome. So you have at least two of the following. You have a patient who has fevers, chills, or any other signs of toxicities that is attributable to CMV reactivation. And those could be, muscle aches, generalized aches, headaches, essentially the symptoms that you would have with viral infection, right? The second one would be presence of leukopenia, presence of atypical lymphocytes on the CBC, presence of thrombocytopenia, or presence of transaminitis, again, with exact definitions as outlined in this table. So CMV syndrome, again, you have 2 or more signs as outlined in this table. So for CMV tissue invasive disease, the consensus definitions first were published in 2017 and were updated in 2024. So again, remember for CMV tissue invasive disease, you need to have A, appropriate clinical symptoms, and B, appropriate documentation that CMV is invading the tissue organ in question, right? And that can be done by histopathology, virus isolation, immunohistochemistry, or hybridization assays. And CMV can affect any organs, especially an immunocompromised host. But for the boards specifically, you need to know these 2 entities, CMV pneumonia or CMV GI disease. That's what you might be asked on the boards. And here is just an image that I got from one of the papers, how the CMV pneumonitis would look like in a patient post-transplant. On the X-ray and the CT, you see evidence of generally bilateral ground glass or more consolidative opacities. Pattern might be different a little bit. Nodules, if it's nodular, generally it's very hazy or ground glass, but different patterns also are observed. In terms of the presentation, it's not, there are no really classic signs for CMV pneumonia, so you will have evidence of general pneumonia symptoms such as hypoxia, non-productive cough, fever, shortness of breath. And for the diagnosis of CMV pneumonia or pneumonitis, either you can make a diagnosis of proven CMV pneumonia based on the evidence of your symptoms or radiographic signs, plus you have an evidence of CMV intranuclear inclusions on a tissue biopsy sample, plus you have an evidence of CMV that is detected by immunohistochemistry staining. The issue with this definition is that most of our transplant patients are not really candidates for biopsies, right? So a lot of times biopsy is avoided, therefore you might conclude that your patient have probable diagnosis of CMV pneumonitis just based on clinical symptoms, imaging, and presence of CMV DNA in the BL fluid. I think for the purposes of the boards, you know, they always want to make sure you know proven or, you know, kind of how you make a gold standard in diagnosis. And in general, you know, we always get a lot of questions because we have a lot of patients that has gone for bronchoscopy and their CMV PCR comes back positive. And then the question is, well, how do you interpret it? I don't think this is a testable point because this is still under investigation. There's still a lot of unknown. But out of all of this information about how you interpret CMV on a BAL, how you interpret that viral load, you should remember that CMV PCR has a very good negative predictive value. So if your CMV PCR is negative on a BAL, it is extremely unlikely that your patient has CMV pneumonia. And then there's a lot of research ongoing in terms of, okay, how do we establish what is the good level of CMV PCR and the BAL saying, well, my patient has CMV pneumonia. So that has not been established. There is no uniform definitions or cutoff, but it appears that the higher CMV level, the higher your probability of having CMV pneumonia. But again, this is all under investigation. I don't think you'll be asked about that. But remember about the predictability. So the question number 3. You have a 53-year-old male, CMV donor positive, recipient negative, heart transplant, who received transplant 12 months ago on immunosuppression with tacrolimus and some systemic steroids, who presents to the office with abdominal pain and diarrhea 6 times a day. So post-transplant, he completed your standard CMV prophylaxis. He had prior history of CMV reactivation with CMV DNA emia, which was treated with valganciclovir. At the time of evaluation in the office, you learned that the patient has mild leukopenia with ANC 1000, CMV PCR blood is undetected, and CT abdomen pelvis showing evidence of mild transverse colitis. Question for you, based on the serology status, how would you classify this patient? High risk. High risk. Okay, so based on the question stem, what is your differential diagnosis here?
Bacterial versus
Infectious
viral.
alkalitis.
Yeah, so it's really unclear, right? What's happening at this point? I mean, because we're talking about CMV and patient had a history of CMV reactivation before. It's definitely in the differential, but based on what they're telling you right now, it's unclear what it is. So based on this, what is your next step?
See,
He needs a colonoscopy, not
he
endoscopy.
needs workup though, so I don't know what they mean by workup, if that includes.
I'm assuming workup includes colonoscopy.
So workup here would be mostly like C. diff, GI panel by PCR, or stool culture. An endoscopy would be like colonoscopy or EGD.
Oh,
So
Includes colonoscopy.
includes colonoscopy?
Yes.
Because I mean, you're not going to reach the transverse colitis,
Yeah.
transfer with the endoscopy. You
colonoscopy
have to do a colonoscopy.
is just endoscopic evaluation.
Okay, so
Or
B.
lower.
So B.
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 Okay. Very good.
I thought that was a trick question.
Yes. So endoscopy could be, upper tract if you have upper GI symptoms, lower tract, lower GI symptoms. But the points to make from this question is that do not be tricked by negative CMV PCR blood, right? So they might test you on this, and remember that CMV viremia may not be present with isolated GI CMV disease. So very, very important to remember. Yes. And this is just a table with definitions of CMV gastrointestinal disease. And for the proven CMV disease, you have to have evidence of, GI symptoms, plus macroscopic mucosal lesions, plus CMV documented in the tissue. So if you look very closely, again, PCR blood, it is not within the definitions how you come up with the diagnosis. Please remember that. Yes.
Why aren't we proceeding with the valve type of your cause? I forgot.
So we are actually why we're not proceeding.
Right, if we have like a suspicion that he might have a CMV. I'm not familiar with valganciclovir, so I don't really know what we need to put in.
Yes. So in this particular question, I think it's on a differential, but we have not made a diagnosis. That's number one. And I think in this particular question in the STEM, it tells you that the patient has diarrhea up to 6 days. So valganciclovir would not be the right choice because you would be concerned about absorption.
Okay.
So if you have concerns for significant GI CMV disease with, your choice would be intravenous ganciclovir if it was in the choice.
Okay.
Yeah, so for GI CMV disease, you might have symptoms, any symptoms from upper to always lower GI tract, and this could be oral ulcers, difficulties swallowing, throat pain, abdominal pain, bloody or watery diarrhea, perirectal ulcerations, everything is possible. And again, remember that CMV viremia may not be present in patients with GI CMV disease, so that's definitely a testable point. Just nice picture to show you how the biopsy appears. So in this picture, you see a classic owl eye intranuclear inclusions as well as intracytoplasmic inclusions. So this would be kind of, a diagnosis of CMV gold standard. And a little bit on the CMV diagnosis. Many years ago, we used to do viral cultures, and they are really not sensitive, very time consuming. So we're going away from the culture for diagnosis of CMV. Also, antigenemia is going out of favor as well. It is definitely not recommended in patients that are leukopenic or neutropenic because this test relies on the identification of PP65 within the neutrophils. So these days, what's used the most is the identification of CMV DNA based on the PCR methods. And you can use plasma or whole blood. You can use other samples. One thing to remember is that make sure you stick to one particular sample type. So plasma compares to plasma, whole blood compares to whole blood. That's important to remember. In terms of serologies, they might ask you, what's the value of serology in post-transplant or in transplant patients. So remember, IgG is used to check or establish serologic status to assess the risk. We generally do not recommend even checking IgMs because they can be falsely positive, or if they're positive after acute infection, they can remain positive for many weeks and even months. So, there is really no role in diagnosis of CMV disease post-transplant based on serologies, okay? So again, serologies, we use pre-transplant to establish the status. After that, the diagnosis is made based on clinical presentation. Definitely, we use histopathology and quantitative NAT for viral DNA. So again, this is just a couple of pictures to show you how CMV appears on a histopathology. And I did show you this picture that shows presence of inclusion bodies in your right upper corner, and the right lower corner, you see how CMV stains on immunohistochemistry. So we kind of touched base about the culture a little bit, definitely not used as much anymore. So now we'll briefly talk about CMV treatment post-transplant. So first of all, let's talk about the medications. So when they give you a question about which meds to use for the treatment of CMV infection or disease, you have four main choices. So you have oral vangacyclovir, then you have intravenous ganciclovir, and oral vangacyclovir is a prodrug of the ganciclovir. You have a foscarnet, and you have cidofovir. So again, when they tell you a question about the treatment, remember these four choices at first. The oral vangacyclovir would be your main drug that you would use in settings of CMV infection with just isolated CMV DNA emia, or if you have a stable patient, let's say with a CMV syndrome, when you prescribe someone oral valganciclovir, you need to make sure that they can take at least 2 to 3 meals per day, because the absorption of valganciclovir is influenced by your food intake. B, you need to make sure that they are not having significant diarrhea or significant GI CMV disease, because in those cases you would be definitely concerned about the absorption. And C, you need to make sure they take the right dose. The issue with it's more like a practical point. The valganciclovir induction dose is 450 milligrams, 2 tablets twice a day. This is your standard induction dose. What we see a lot of times when we have issues with control in CMV infection is that patient is not taking the right dose. Either they take 1 tablet BID or they take 2 tablets once a day. So, but again, always check if the patient is taking correct dosing. Another point to make is that a lot of times patients come in dehydrated. There is some component of renal failure, and we dose the medication based on their current creatinine. 5 days later, creatinine is back to normal, but we forgot to adjust the medication. Again, the dosing for any CMV drugs is extremely important. And I'll show you later, actually, when we talk about resistance. Resistance happens, but definitely not very common. And the most important issues that we identify when we cannot control CMV levels, again, either there's a problem with absorption or we are not dosing the medication correctly. So that's about that. The foscarnet is definitely used, especially in patients with a significant leukopenia pre-engraftment. However, a big issue with renal insufficiency, right, and nephrotoxicity. Cidofovir, thankfully, we do not use it a lot these days unless you have a patient with this very complex resistance mutation patterns. Occasionally is used in patients with refractory and resistant CMV. However, same issue with foscarnet, so significant nephrotoxicity. When you have a patient with a CMV infection, always talk to the transplant team regarding if there is any way to reduce immunosuppression, right? So this is very important. And studies have shown that the patients that, for example, were on 2 immunosuppressive drugs comparing to 3 immunosuppressive drugs have done much better in terms of controlling their CMV infection or disease. When you're treating CMV infection or disease, monitor your renal function and blood counts very carefully, mostly to assess for toxicities of whatever drugs you're using. And this is just a table for you guys to review. If kind of shows you all of these drugs that most commonly used for the treatment of CMV infection, and also shows you how they mechanism of action and where the resistance genes come into play. So in terms of how we treat CMV post-transplant, you start your drug, you monitor the CMV DNA levels every week. It is not recommended to monitor levels more often than every 5 to 7 days, because if you monitor it more frequently, you are not going to see a significant improvement. Also, what's important to remember is that in the first 2 weeks of your treatment, you might have this paradoxic increase in your CMV viremia levels. However, if your patient is doing well, it is recommended that you continue current therapy. We generally continue treatment until your CMV becomes undetectable for 1 or 2 weeks in a row. So most of the patients, they receive at least 2 to 3 weeks of therapy. And the patients with a significant CMV disease, it's recommended that they receive at least 3 weeks of therapy. Some patients might require much longer therapy, up to 6 weeks, and occasionally we have patients that require it for longer. Okay. So here's a question, kind of the same patient that we had in question number 3. So same patient that we started on foscarnet on day 14 for asymptomatic CMV reactivation. The team calls you at day 19, stating that your CMV PCR blood increased to 5,000 international units. However, the patient is doing well with normal kidney function, but she's still neutropenic. So the question is, what is your next step in terms of CMV management? Continue foscarnet and recheck CMV. Change foscarnet to IV ganciclovir. Continue foscarnet, send for resistance testing. Change foscarnet to maribavir. Everybody agreed on A. Yes, so as we discussed, it is common to experience either a temporary increase, transient increase in your CMV levels in the first 2 weeks of treatment. However, if your patient continues to do well, it's recommended that you do not change treatment, you continue current management. And this is a testable question. So remember that. And here I included 2 tables with the drugs that we talked about. It goes over the mechanism and the regimens or the dosing and main side effects. Again, that's if you guys like tables. Yeah.
Is there actually, I mean, I remember on BMT, it mentioned something about a threshold for which you see that paradoxical increase. Even if it goes beyond that threshold, then you still have to become concerned about resistance testing. Was it like a half log or 1 log up? What was the actual threshold for which you'd actually?
Yes, that's a good question. I think you have a question about refractory resistant CMV, right? And
yeah,
when we would be concerned about it. So to answer your question, with CMV levels, you want to see a 1 log reduction, right? So if your patient is appropriately responding, you anticipate to see a drop in CMV levels at least by 1 log, right? And another, teachable moment is that when you look at the numbers for these viruses, right? You do want to look at the number, but you really want to look at the log, right? Because, for example, if your initial level was 10,000, right? And 2 weeks later, I get a level and it's, for example, 9,000. The number might look better, right? But I might get concerned because there's no, that, expected reduction of 1 log did not happen, right? So again, look at the log, look at the numbers, but calculate your log to make sure that your patient is appropriately improving. Yes, so then we're moving to a refractory resistant CMV infection definitions. And they can test you on this for 2 main points. They want you to know about this new drug which is on the block, which is called maribavir, and they might test you on 2 specific mutations. So this table has the definitions for refractory and resistant CMV infection. So refractory CMV infection is defined as you have a persistent virus after 2 or more than 2 weeks of appropriately dosed antiviral therapy. And the resistant CMV infection is defined as that you have a patient with refractory CMV infection who also has an evidence of resistance based on your resistance testing. And these are your main risk factors for refractory/resistant CMV infection or disease. One of the most important risk factors would be a previous antiviral exposure with prolonged antiviral treatment. And this is defined as that you have a patient that has received more than 6 weeks of therapy or prophylaxis in the past. So this is one of the most important risk factors. And of course, the patients that are highest risks based on sera status, as we discussed before, patients with very high levels of CMV DNA EMEA are at risk for resistance as well. And patients that are on a high level of immunosuppressants are also at high risk for resistance. And this is mostly because those patients generally require very extended courses of therapies and again have been heavily exposed to CMV treatment of prophylactic drugs. So remember, 6 weeks. 2 mutations that they might test you for is a UL97 and UL54 DNA polymerase gene mutation. And the UL97 mutations or mutants generally are overcome by foscarnet and cidofovir therapy, but UL54 mutations is the one that you need to remember that it confers cross-resistant to ganciclovir as well as other drugs. So that's a really bad one to have. And then in the guidelines for the management of CMV infection in solid organ tumors, they give you this nice table to kind of make a decision what you do with your therapy when you are concerned about refractory or resistant infection. So generally the flow goes like this. If you have a patient at kind of 2-week mark that you determine is not responding to your standard therapy, for example, with IV ganciclovir, at that point, it is recommended that you send for resistance testing and you change your drug. So generally, we change the drug from IV ganciclovir or valganciclovir to foscarnet and wait for resistance. If resistance testing comes back as no resistance, it means that most of the times there's a problem with either a absorption or an appropriate dosing, or your patient is on a lot of immunosuppression, and you really need to work with your transplant colleagues in order to see how we can reduce immunosuppression. So those patients, essentially, you again, make sure that you do not need to increase ganciclovir dosing or change the mode how you deliver it. So change from PO valsite to IV ganciclovir, and again, try to reduce immunosuppression. And then if your resistant testing comes back as, for example, ganciclovir resistant, then it will actually tell you what is the level of resistance to ganciclovir. It could be moderate, mild to severe, mild, moderate to high level of resistance. With a low level of resistance, you can actually overcome it a lot of times with higher doses of ganciclovir. For other degrees, yes, generally we recommend that the drug is changed to overcome the mutation. So maribavir is actually an old drug, but was relatively recently approved for the treatment of refractory and resistant CMV infection, and therefore you can be tested on this. So again, remember that the indication for this drug is treatment of refractory and resistant CMV infection. It is not approved drug for prophylaxis. We generally use it in patients that for some reason cannot tolerate foscarnet or have contraindications to ganciclovir. Again, based on the safety profile of those other two drugs that I mentioned. There is an European society that studies infections in patients with leukemia. It's called the ECIL, stands for European Conference for Infections in Leukemia Patients. So they issued a statement in 2024 that maribavir can be considered as the first-line treatment for patients with neutropenia or renal impairment or unsuitable for therapy with valganciclovir or foscarnet. Also remember that maribavir is not active against other viruses except EBV in vitro. So you still need to continue your VZV, HSV prophylaxis, even if your patient is taking maribavir. And very quickly on CMV prevention post-transplant. So when you have a question about CMV prevention post-transplant, you have to think about two modalities. So you have one, antiviral prophylaxis, and the second modality is preemptive therapy. And here on the right, you see what preemptive therapy means. Preemptive therapy means that after transplant, you initiate weekly CMV monitoring. And when your patient is found to have asymptomatic CMV viremia, you initiate them on the treatment. So I'll skip this for because we're running short on time. So here is another important table that outlines differences in terms of prevention. So for solid organ transplants, again, remember that the highest risk is donor positive, recipient negative. Antiviral prophylaxis is generally preferred over preemptive therapy in solid organ transplant patients. Generally, those patients receive oral valganciclovir for a defined duration. However, recently, remember that letermovir was approved for prophylaxis, at this point only for kidney transplant. So remember that. In patients that underwent hematopoietic stem cell transplant, traditionally we used preemptive therapy, and this is, mostly because we were not able to use valganciclovir for prophylaxis because of profound neutropenia, right? However, again, recently letermovir was approved for prophylaxis, so this completely changed this particular field. And now it is recommended that your highest risk patients that are recipient positive receive letermovir for CMV prophylaxis post hematopoietic stem cell transplant. So these are the main differences, and this is just additional information on letermovir. Remember 2 indications. So for letermovir, you're going to remember 2 indications: prophylactic only at this point, in recipient positive allogenic stem cell transplants, or prophylaxis again only in high risk donor positive recipient negative kidney transplants as an alternative to valganciclovir. It has no activity against other herpes viruses. So again, if you have a patient on letermovir, you need to have them on prophylaxis for HSV and VZV. It has major drug interactions with immunosuppressant drugs, voriconazole, and long list of drugs. So you have to work with the pharmacist to make sure that you do not need to adjust any other medications when your patient goes on letermovir. So kind of in a nutshell, when you get a question on CMV post-transplant, first of all, you ask yourself, am I dealing with SOT or HCT? What is your donor recipient CMV status? Look at that so you can determine if your patient is at highest risk versus intermediate versus low. And then when you get a question about treatment versus prevention, then again, ask yourself whether you're dealing with asymptomatic anemia or you're dealing with tissue invasive disease. And then again, kind of go through your main drugs that are approved for the treatment, and based on their safety profile and side effects, decide which antivirals suits your patient the most. And if you're interested in CMV or just want to learn more, I highly encourage you. There are 3 episodes on Febrile podcast that cover CMV. They're absolutely excellent. So make sure you listen to those. And that's what I have for you guys today.